Welcome back to the deep dive. Today, we are doing something a little different. We're taking that little white pill, the one you take for a headache or the capsule prescribed for an infection, and we're essentially shrinking ourselves down to the molecular level to follow it into the dark.
It really is a journey into the dark. We have this tendency to view medicine as a very clean, sort of linear transaction. You swallow a pill, it goes to the pain, and it fixes it. But the reality, as described in the source material for today, is so much more chaotic. It's really a war zone down there.
It's a war zone, exactly. We're looking at the fundamental texts of pharmacology today. We've got Katzung and Trevor's Basic and Clinical Pharmacology and Goodman and Gilman's The Pharmacological Basis of Therapeutics. And if there was one headline from these chapters, it's that the human body is not designed to accept medicine. It is designed to act as a fortress.
That is the absolute central tension of this entire deep dive. Evolution has spent millions and millions of years building walls, moats, and literal acid baths to keep foreign molecules out. So when you take a drug, your body doesn't say, oh, thank you for the help. It says intruder. And it activates this massive, unbelievably complex biological machine to block it, to break it down, and to flush it out.
So the science of pharmacokinetics, which is our topic today, is really the story of a heist. How does the drug breach the walls? How does it evade the guards? And how does it reach the safe before the whole security system destroys it?
That's a fantastic way to frame it. Today is an interpretive synthesis of these two heavy-hitting textbooks. Katzung gives us that clinical scaffolding, the how to think like a doctor part. Goodman and Gilman gives us the deep molecular reasoning, the why the system works this way part. But I want to be really clear right up front. This conversation is a map. It's not the territory. We're going to give you the conceptual framework, but you absolutely still need to go back and read the chapters on pharmacokinetics.
Right. Consider this your pre-flight briefing. We are going to open the black box. Usually we just think about the dose. I took 500 milligrams, and then we think about the effect. My fever broke. But everything that happens in between those 2 points is what determines if a drug works, if it's toxic, if a patient lives or dies. And the sources give us this really elegant acronym to track the journey, ADME.
ADME. Absorption, distribution, metabolism, and elimination. These are, in a way, the 4 protagonists of our story today. Absorption is getting in, distribution is moving around, metabolism is breaking down, and elimination is getting out.
Okay, but before we start the heist, we need to clarify the mission. The sources make a really, really sharp distinction between 2 big words that sound almost identical, pharmacokinetics and pharmacodynamics, PK and PD.
It sounds like, academic hair splitting, but it's probably the most fundamental distinction in the entire field. Think of it this way. Pharmacokinetics, the PK part, is what the body does to the drug.
So the body is the actor, the drug is just the object being acted upon.
Exactly. Correct. The body absorbs it, it moves it around, it chews it up, and it pees it out. That's PK. Pharmacodynamics, PD, on the other hand, is what the drug does to the body. That's the mechanism. That's the drug binding to a receptor to lower your blood pressure or inhibiting an enzyme to kill a bacteria.
So today we are strictly talking about the commute, not the destination.
We are only talking about the commute. But the reason the commute matters, and Katzung has this fantastic conceptual map, figure 3.1, linking them, is because of one crucial variable, concentration. You see, as a clinician, you cannot prescribe an effect. You can't write on a prescription pad, lower blood pressure by 10 points. It's impossible. You can only prescribe a dose.
You only control the input, but the output, the effect, that depends on the system.
Precisely. The bridge between the dose you give and the effect you want is the concentration of the drug in the blood. If the concentration is too low, nothing happens. It's useless. If it's too high, you get toxicity. You poison the patient.
And this is that target concentration idea. We're trying to land a plane on a very, very narrow runway.
Ideally, yes. And pharmacokinetics is the instrument panel that helps us land that plane. It's the math that tells us, okay, if I give this much drug to this specific person with this kind of kidney function, what concentration will I actually get?
And that's where the whole standard patient myth just completely falls apart, right?
Yeah.
Because my fortress might be stronger than yours, my liver might be faster, my kidneys could be slower.
Completely different. Every single person is a different fortress. And that's why this matters. Rational dosing isn't about memorizing a number from a handbook. It's about understanding the variables of the system you're working with.
So let's start at the beginning. The first gatekeeper, the letter A, Absorption.
Absorption. It seems so intuitive, right? You swallow the pill, it's inside you. But strictly speaking, just because something is in your stomach, it is not inside your body yet. The GI tract is essentially a tube that runs through the body. It's open to the outside world at both ends.
There's a deeply disturbing but very accurate image.
Yeah.
So for a drug to actually be absorbed, it has to cross the barrier from that tube into the blood.
Correct. That's the definition. Absorption is the movement of a drug from its site of administration into the systemic circulation. And this brings us to one of the most critical numbers in all of pharmacology, bioavailability.
Represented by the letter F.
F for fraction. It is the fraction of the administered dose that actually reaches the systemic circulation unchanged. It's a number that can be anything between 0 and 1.
So if F is 1, that means 100% of the drug made it into the bloodstream.
Yes, and there is basically only one way to guarantee that F equals 1.
The IV drip.
Intravenous administration. We call it the VIP entrance. You are bypassing the fortress walls entirely. You're not even knocking on the door. You're taking a syringe and injecting the molecule directly into the vein. There is no barrier to cross. So by definition, bioavailability is 100%. F equals 1.
Which is why, in an emergency like a heart attack or a major seizure, we always go IV. We need certainty and we need speed. We don't have time to negotiate with the fortress walls.
Exactly. We need total control. But IV is invasive. It's inconvenient. It requires a sterile setting, a trained professional. You can't send a patient home with an IV pole and say, "Good luck, call me in a week." So for the vast majority of chronic medicine, we rely on the oral route.
The mouth.
The mouth. And Goodman and Gilman describes oral administration as the most common, the most economical, and yet the most treacherous path a drug can take.
Treacherous is a very strong word for swallowing a Tylenol. Why is it so dangerous for the drug molecule?
Well, just walk through the physics of it. You swallow a tablet. First, it has to disintegrate. It has to dissolve. If it doesn't dissolve into solution in your gut, it can't be absorbed. It'll just pass through you like a tiny stone.
Okay, so step 1 is it has to dissolve.
Now it's floating in stomach acid. That's a pH of, 1 or 2. It's a highly corrosive environment. Some drugs are just destroyed right there. Penicillin G, for example, is very unstable in acid. It just falls apart. If they survive that, they move to the small intestine. Now they have to physically cross the gut wall.
The main barrier.
The barrier. The gut wall is lined with these epithelial cells packed tight together. And those cells are covered in a membrane that is essentially a layer of fat, a lipid bilayer.
So it's like a grease wall.
It is exactly like a grease wall. So if your drug is hydrophilic, if it loves water and hates fat, it just bounces right off. It cannot permeate the wall. If the molecule is too large, it can't fit through. If it's highly charged, it gets repelled by the charges on the membrane. The chemistry has to be just right.
So you could technically swallow a pill and have 0% of it enter your body just because of the chemistry of the molecule itself.
Absolutely, 100%. Vancomycin is a powerful antibiotic. We give it IV all the time for really serious systemic infections. But if you take it orally, it is not absorbed at all. It stays in the gut. Now, sometimes we actually do that on purpose to kill bacteria that are in the gut, like for a C. diff infection. But if you were trying to treat pneumonia with oral vancomycin, the patient would die because the bioavailability is 0.
Okay, but let's assume the drug is designed well. It's lipid soluble, it's small enough, it successfully crosses the gut wall. It's in the body now, right? We've made it.
Geographically, yes, but physiologically, no. And this is the part that really blows people's minds. The anatomy of the human body plays a dirty trick on orally administered drugs.
The portal vein.
The portal system. You see, nature evolved this system to protect us from eating poisons in our food. So the blood vessels that drain the stomach and intestines do not go to the heart first. They don't go to the brain. They funnel every single drop of blood from the gut directly into one organ, the liver.
The first pass effect.
The first pass effect. It's a mandatory customs checkpoint. The liver is the body's main detox center. Its entire job is to identify foreign chemicals and metabolic waste and, well, destroy them. So an oral drug gets absorbed, it rushes to the liver, and the liver enzymes, specifically the cytochrome P450 family, attack it immediately.
Before it has even circulated once to the rest of the body. Not even one trip.
Before it has reached a single target organ, the liver demands attacks. We call it first-pass elimination or first-pass metabolism. For some drugs, this tax is pretty small. The liver kind of ignores them and lets them pass. But for others, the tax rate is confiscatory. It's brutal.
The sources mention lidocaine as the classic example here. Lidocaine is that numbing agent dentists use, or we use it to treat heart arrhythmias.
Right. We use lidocaine the VEAT all the time for ventricular arrhythmias. It's a cornerstone of cardiac life support. But have you ever seen a lidocaine pill?
No, I can't say that I have.
And you never will, because the liver is so incredibly efficient at breaking down lidocaine that if you swallowed it, the liver would extract and metabolize almost 100% of it on the first pass.
Wow. So the bioavailability would be near zero.
Effectively zero. It's completely useless orally. You'd have to swallow a bucket of it just to overwhelm the liver enzymes, and by then the toxic metabolites created by the liver would probably kill you.
Propranolol is another one mentioned in Goodman and Gilman. It's a beta blocker. People use it for blood pressure, performance anxiety.
Propranolol is a really interesting case. The liver destroys a huge chunk of it, but not all of it, so we can give it orally. But the dose is massive compared to the IV dose. You might give 40 or 80 milligrams orally to get the same effect as a tiny 1 or 2 milligram IV injection.
So you're basically just feeding the liver. You're sacrificing most of the drug just to get a little bit through.
That's a great image. You're paying a massive bribe to the bouncer just to get one friend into the club. And here is where the standard patient problem comes back to haunt us. What if your bouncers are sick? What if you have liver failure or cirrhosis from alcoholism?
And the bouncer is asleep on the job. The gate is wide open.
Right. The metabolic capacity of the liver drops, the tax isn't collected, so that 80 milligram dose of propranolol, which is usually safe because the liver eats most of it, suddenly all 80 milligrams gets through to the heart.
And you have a massive overdose.
A massive overdose from a standard pill just because the gatekeeper was down. So absorption isn't just did they swallow it, it's how much survived the gauntlet of the gut and the liver. That's bioavailability.
Okay, so we've survived the stomach, crossed the membrane, paid the liver tax, and now the drug is finally in the systemic circulation. It's in the blood. Now we move to the second letter of our acronym, D, distribution.
Distribution, the geography of the body.
This is where I started to struggle a bit with the reading, I have to admit. I have this mental image of blood pumping around. It feels like a simple loop. But the sources introduced this concept of volume of distribution, or V, and they keep emphasizing that it's an apparent volume, an imaginary tank.
It is the concept that breaks the most brains in Pharmacology 101, no question. But it's so crucial for understanding where the drug actually goes once it's in the body. Let's just look at the equation first. It's simple. V equals the amount of drug in the body divided by the concentration of the drug in the plasma.
Okay, V equals amount over concentration. Looks simple enough.
But let's apply it to see why it's so imaginary and weird. Let's look at two different drugs, both mentioned in CatSum. First, a drug that likes to stay in the water. It's hydrophilic, it's large, it can't easily leave the blood vessels, so you inject it, and it pretty much stays right there in the plasma.
Okay, so the concentration on the plasma sample would be pretty high.
Very high concentration. Now look at the fraction. Amount divided by a high number gives you what?
A small number.
A small volume. For these drugs, the volume of distribution is usually around 3 to 5 liters, which makes perfect sense because that's roughly the actual physical volume of blood plasma in an adult human being. The math matches the anatomy, no problem.
Okay, I'm with you so far. But then you have a drug like chloroquine.
Chloroquine, the anti-malarial drug.
The sources say the volume of distribution for chloroquine is something like 13,000 to 15,000 liters.
Right. It's massive.
Wait a minute. A human body is, what, 70 kilograms?
Right.
We contain maybe 42 liters of water in total. How can a drug have a volume of 15,000 liters? That's the size of a small swimming pool.
It is, and obviously the patient does not inflate into a swimming pool. This is why we call it an apparent volume. It's a mathematical abstraction. What that huge number is telling you is that the denominator in our equation, the plasma concentration, is tiny.
Tiny.
Vanishingly small. You inject the chloroquine, and it disappears from the blood almost instantly.
So where does it go?
It goes into the tissues. Chloroquine is highly lipophilic. It loves fat. It binds to melanin. It gets taken up by the retina and the eye. It binds to muscle. It binds to the liver. It sequesters itself deep in the body's solid structures. So if you draw a blood sample to measure the concentration, you find almost nothing. When you plug that tiny, tiny concentration into the equation, the math says, wow, for the concentration to be this low, the tank must be enormous.
I see. So a huge volume of distribution is just code. It's code for the drug is not in the blood, the drug is hiding in the tissues.
Precisely. It's the sponge effect. That's the best analogy. Imagine a bucket of water representing the blood, with a giant dye sponge in the bottom representing the tissues. You pour a bottle of red dye into the water. The sponge immediately sucks up 99% of the dye. The water in the bucket looks almost clear. If you tested just the water, you'd say, there's almost no dye here. This bucket must be the size of a lake to dilute it this much. But it's not a lake. It's just a really thirsty sponge.
Why does this matter clinically? Why do I care if the drug is in the blood or in the sponge, as long as it's in the body somewhere?
You care deeply if you need to get it out. Let's say a toddler swallows a whole bottle of chloroquine. It's extremely toxic. You rush them to the ER. The standard way to clean someone's blood in an overdose is hemodialysis. You hook them up to a machine that filters the blood.
But the drug isn't in the blood.
Exactly. The drug is in the tissue, it's in the heart muscle, and the brain. You can scrub the blood crystal clear for hours and it won't matter because 99.9% of the poison is sitting in the tissues. You cannot dialyze a drug with a huge volume of distribution. It's futile.
That is a terrifying thought. It completely changes your rescue strategy.
It does. Conversely, if a drug has a small volume, if it stays in the blood, like our first example, dialysis works great. So knowing the V tells you where the enemy is hiding and whether you can even get to it.
There's another aspect of distribution that Goodman and Gilman highlights, and that's the bus system. Protein binding.
Ah, yes, the albumin bus. Your blood isn't just salt water, it's full of proteins, and the main one is albumin. Albumin acts like a carrier molecule, a shuttle bus. Many drugs, as soon as they enter the blood, immediately attach themselves to albumin.
They hop on the bus.
They hop on the bus. But here is the critical, non-negotiable rule of pharmacology. Bound drug is inactive. While a drug molecule is attached to albumin, it cannot cross membranes, it cannot bind to receptors, it cannot be filtered by the kidney. It is effectively in storage. Only the free drug, the drug that's walking on the sidewalk, can actually do the work.
So if a drug is listed as being 99% protein bound,
then only 1% of the total amount of drug in your body is actually doing anything at any given moment. The other 99% is just riding the bus.
that seems incredibly inefficient.
It's actually a buffer system. As the free drug gets used up or eliminated from the body, more drug hops off the bus to replace it. It helps maintain a steady trickle of active drug, but it creates a huge danger zone called displacement.
What happens there?
Imagine the bus is full. You have a patient taking a blood thinner like warfarin, which is highly protein bound. The bus seats are 99% occupied by warfarin molecules. Then you give that patient a second drug, maybe a sulfonamide antibiotic. The antibiotic also likes to ride the bus, and maybe it binds even tighter to the protein. It's a bully. It kicks the warfarin off the seat so it can sit down.
So now the warfarin that was on the bus is walking on the sidewalk.
Exactly. Suddenly, your free fraction of warfarin goes from 1% to 2%.
It sounds like such a small number change, 1 to 2%.
But think about the ratio. It's a 100% increase in the active dose. You have literally doubled the potency of the blood thinner without the patient swallowing a single extra pill. And suddenly, they can start bleeding internally, just because of a traffic jam on the albumin bus.
It's amazing how dynamic this is. It's not just drug in, drug out. It's drugs fighting each other for space. The sources also talk about how distribution happens over time. It's not instant. They describe this two-compartment model.
This is the urban planning analogy of the body. Think of the body as having a downtown and the suburbs. Downtown is the central compartment. It's the blood and the highly perfused organs. The heart, brain, kidneys, liver, they get a ton of blood flow. When you inject a drug IV, it goes downtown instantly. Within a minute, the concentration in the heart and brain is very high.
Okay, that makes sense. High traffic areas get served first.
The suburbs are the peripheral compartment. That's your muscle, your skin, your fat, your bone. The blood flow there is much slower. It takes time for the drug to commute out to the suburbs. So the drug rushes into the heart and brain first, causing an immediate, powerful effect. Then, slowly, over the next few minutes or hours, it diffuses out to the suburbs, the fat and muscle.
And this explains the phenomenon of redistribution, right?
Yeah.
The sources use thiopental as the classic example. It's an anesthetic.
Exactly. In the movies, when they inject the guy and he falls asleep before he can finish his sentence, that's the open towel. It's extremely lipid soluble, so it crosses into the downtown almost instantly. The brain gets so much blood flow, patient is out cold. But then something weird happens. The patient starts to wake up pretty fast, like in 10 or 15 minutes.
So did the body eliminate the drug that quickly?
No, not at all. The drug is still very much in the body, but it redistributed. It moved from the brain to the muscle and fat. The concentration in downtown dropped because everyone moved to the suburbs. So the patient wakes up not because the drug is gone, but because the drug went to the fat tissue where it doesn't cause sleep. The effect is terminated by redistribution, not elimination.
That really clarifies why the timing of the effect can be so different from the actual presence of the drug in the body?
It's all about location, location, location. Just because it's in the body doesn't mean it's in the brain.
Okay, so we've absorbed A, we've distributed D. The drug has hopefully done its job. Now the body wants it gone. This moves us to M and E, metabolism and elimination. And the sources group these together under the single most important concept of clearance.
Clearance. If you take one thing away from this entire deep dive, if you zone out for the rest of it, listen to this part. Clearance is the single most important concept for rational, long-term dosing. Goodman and Gilman is very explicit about that.
But the definition is tricky. It's not what you think it is.
It is extremely counterintuitive. When people hear clearance, they think amount. They think, my body cleared 50 milligrams of drug in an hour. That is not what clearance means.
So what does it mean?
Clearance is a measure of volume. It is the volume of biological fluid, like blood or plasma, that is completely cleaned of drug per unit of time. The units are milliliters per minute, mLm, or liters per hour.
Can we use an analogy here? I'm having a hard time visualizing volume cleaned.
Let's go back to the swimming pool analogy. Imagine you are cleaning a dirty swimming pool. You have a pump with a filter attached. The pump is pulling water out of the pool, running it through a miraculous filter that instantly makes it 100% clean, and then pouring the clean water back in. Your clearance is the flow rate of your pump. Let's say your pump can process 10 liters per minute. That's your clearance. It's a property of the system of your pump and filter, not a property of how dirty the water is.
Okay, so my pump's capacity is 10 liters per minute. That's a constant.
Right. Now, if the pool is absolutely filthy, a high concentration of dirt, those 10 liters you process will remove a huge amount of dirt. If the pool is almost clean, a low concentration, those same 10 liters you process will remove very little dirt. The amount of dirt removed changes constantly, but the clearance, the 10 liters per minute, stays constant for most drugs.
I get it now. So the kidney is the pump and filter.
The kidney is the main pump. The liver is also a pump. And because they work in parallel, their effects are additive. Systemic clearance equals renal clearance plus hepatic clearance plus any other minor routes like sweating or breathing a drug out.
Let's talk about the kidney, because this is where things go wrong for so many patients, especially as they get older.
Yeah.
The sources have this really depressing statistic about aging and kidney function.
It is the reality of human biology. Starting in our 20s or 30s, our renal function, our kidney's ability to filter blood, begins a slow, steady decline. It drops about 1% per year on average.
1% per year.
It's imperceptible from one year to the next. But do the math. Compare a healthy 25-year-old to a healthy 85-year-old. The 85-year-old might have lost 50% or 60% of their kidney function just from natural aging. No disease, just time.
So their pump is only running at half speed.
Exactly. Their clearance is cut in half. Now imagine you give that 85-year-old the standard adult dose of an antibiotic that's cleared by the kidneys. The rate of drug in is the same, but the rate of drug out is halved.
The pool overflows.
The drug accumulates, the concentration rises day after day, and suddenly a standard dose becomes a toxic overdose. This is why start low and go slow is the absolute mantra for geriatric medicine. You have to assume the clearance is compromised until proven otherwise.
And the liver, it clears things too, but it does it differently. It doesn't just filter, it metabolizes.
The liver is the chemical engineer of the body. Its main job is biotransformation. It takes drugs, which are often fat-soluble, and it attaches chemical groups to them to make them water-soluble. Once they're water-soluble, the kidney can grab them and pee them out. Or the liver can package the drug up and spit it directly into the bile.
And the bile gets dumped into the intestine, which leads to one of the most frustrating loops in all of pharmacology, enterohepatic cycling.
The body's own recycling plant. It's wild. The liver works hard to extract a drug from the blood and dump it into the gut via the bile. But as that drug travels down the intestine, sometimes the gut wall says, hey, I recognize this molecule, and reabsorbs it right back into the portal blood.
So it just goes in a circle, gets kicked out the front door, and sneaks in the back.
Liver to bile to gut to blood, and back to the liver. It's like trying to throw an unwanted guest out of a party, and they keep sneaking back in through the bathroom window. This can keep a drug in the body for a very, very long time, significantly extending its duration of action.
So we have the mechanism of clearance. But how does this play out over time? This brings us to part 4. Time is a variable, and there is a celebrity statistic here, the one everyone kind of knows, the half-life.
2.5, the half-life.
The definition is simple enough. The time it takes for the plasma concentration of a drug to drop by 50%. But the equation for half-life is beautiful because it connects everything we've just talked about.
It does. The equation is approximately 2½ equals 0.693 times V divided by CL. Don't let the 0.693 scare you. That's just a math constant, the natural log of 2. Look at the variables. Half-life depends on two things we just defined: volume V and clearance, CL. It is directly proportional to volume and inversely proportional to clearance.
Let's go back to the tank analogy. That seems to work well.
Perfect. V is the size of the tank. CL is the size of the drain pipe at the bottom of the tank. The half-life is the answer to the question. How long does it take to drain half the water out of the tank?
Okay, if I have a massive tank, a huge volume of distribution, it's going to take a long time to drain.
Right. A big V means a long half-life. The drug is hiding in the tissues. It has to leak back out to be eliminated. Now, what if I have a really tiny drain pipe? A low clearance.
Also takes a very long time to drain.
Exactly. A low CL means a long half-life. So when we see a patient with a long half-life, meaning the drug is staying in their system forever, we have to ask the critical question: did the tank get bigger? Or did the drain pipe get clogged?
And in renal failure, it's obvious the drain pipe is clogged.
Correct. But here is a nuance that Katsung points out, which is tricky and can trap even experienced doctors. Sometimes, in the elderly, the tank shrinks too. Take the heart drug digoxin. Digoxin binds to muscle. It has a large volume of distribution because it hides in the muscle mass. But elderly people often have sarcopenia, muscle atrophy. They have less muscle mass.
So their personal digoxin tank is smaller than a younger person's.
Right. So their V goes down. But their kidneys are also old, so their CL also goes down. If the numerator of the fraction B drops and the denominator CL drops by a similar amount, the final fraction might stay the same.
So the half-life could look normal.
The half-life might be completely unchanged. You look at the timing and you think, oh, they're clearing it just fine.
Yeah.
But because the tank is tiny, the concentration for a given dose shoots through the roof. You can have a normal half-life and still have profoundly toxic concentrations.
That is a very dangerous clinical trap. It reinforces that you can't just look at one number in isolation. You have to look at the whole system.
Always the patient, never just the number.
So half-life tells us how fast a drug leaves. But it also dictates the rhythm of dosing. And it leads to this critical concept of steady state, the plateau.
Steady state is the goal of all chronic maintenance dosing. When you start taking a drug, say 1 pill every morning, you don't reach full effectiveness on day 1. You take a dose, the level in your blood goes up, then it starts to fall. Before it's all gone, you take the next dose. It adds to the leftover amount from the first dose, so the level goes a bit higher. It creates a sawtooth pattern, climbing up and up with each dose.
Until eventually, the rate in equals the rate out.
Precisely. The amount of drug you're putting in with each pill is exactly equal to the amount of drug your body is clearing in that same time period. The bucket is draining as fast as you are filling it. The level stabilizes, oscillating around an average. That's steady state. And there is a rule of thumb here that is universal in PK.
The 4 to 5 rule.
It takes 4 to 5 half-lives to reach about 95% of steady state. It doesn't matter how big the dose is. It doesn't matter how often you give it. It is strictly a function of the drug's half-life.
So if a drug has a half-life of 24 hours, like a once-a-day pill,
it will take 4 to 5 days to reach stable blood levels.
That seems fine for, say, a blood pressure medicine. But what if a drug has a really long half-life, like 10 days?
Then you are waiting 40 to 50 days to reach steady state, nearly 2 months.
And if the patient is dying of an infection, or they're in the middle of a dangerous heart arrhythmia,
you can't wait 2 months. They'll be dead.
So how do we cheat the math? This brings us perfectly to part 5, clinical application. We need to talk about the loading dose versus the maintenance dose. And to do this, let's use the case study from Katsung. It's brilliant.
The 85-year-old woman with atrial fibrillation. This is a classic board exam scenario that illuminates everything we've just discussed.
Let's set the scene. She comes into the ER. She's 85 years old. She weighs 60 kilograms. Her heart is an AFib. It's beating irregularly and way too fast. We need to slow it down with digoxin. But her lab work comes back. Serum creatinine is 1.8 milli-GDL.
Stop right there. That number is everything. For a gym-going 25-year-old male, a creatinine of 1.8 is borderline concerning. For an 85-year-old woman with low muscle mass, a creatinine of 1.8 is a siren screaming kidney failure. Her renal clearance is severely, severely depressed.
So we have a dangerous drug, digoxin, a failing organ, the kidney, and an urgent clinical need, her racing heart. We have a target concentration in mind that we want to achieve. Let's say it's 1 nanogram per milliliter. How do we dose her?
We need two completely different calculations for two different doses. First, we need to establish the maintenance dose. This is the keep the tank full dose, the dose she'll take long term. And maintenance depends on the drain pipe. It depends on clearance.
The equation is dosing rate equals clearance times the target concentration.
Right. Because her clearance is terrible, the math will tell us to give her a very, very small daily dose, maybe 0.125 milligrams every other day, a tiny trickle. If we gave her a standard dose, the drain couldn't handle it, the tank would overflow, and she would spiral into toxicity.
Okay, so we've calculated the tiny pill she needs. But we have the 4 to 5 half-life rule. Because her clearance is so low, her half-life is going to be really long. It might take her 2 weeks to reach steady state on that tiny pill. Her heart is racing now. We can't wait 2 weeks.
So we need a loading dose. We need to fill the tank instantly, right now. Now, ask yourself this critical question. Does the size of her tank, her V, depend on her kidney function?
No. The tank size is the tank size. It's her tissue volume, her muscle mass. It has nothing to do with her kidneys.
Exactly. The volume of distribution is largely independent of the clearance. So remarkably, her loading dose might be almost the same as a healthy person's loading dose. The equation is loading dose equals volume times target concentration. No clearance in that equation.
That feels so incredibly counterintuitive. You're telling me I can give a massive normal-sized first dose to this fragile lady with kidney failure?
Just once, to fill the tank. If you gave her a renal-adjusted loading dose, a tiny dose, you would only fill the tank up to her ankles. It wouldn't reach the therapeutic concentration. It wouldn't work. The loading dose is about filling the space, not about offsetting the drain.
So the strategy is fill the tank up to the brim immediately with a big loading dose, then switch to a tiny trickle of a maintenance dose to keep it there.
That is rational dosing in a nutshell. And Katsang puts a giant red warning label here. You have to be extremely careful how you put that loading dose in.
The rate of administration.
Yes. Remember our two-compartment model, downtown and the suburbs. If you calculate the correct loading dose for her whole body, but you shove it all into her vein in 10 seconds.
It all sits downtown for a few minutes in the central compartment.
It hasn't had time to diffuse to the suburbs yet. So for those first 15 or 20 minutes, the concentration in her heart and her brain, which are downtown, is astronomically high. It's a temporary mathematical overdose restricted to the central organs. You could stop her heart right there.
So even though the total amount of drug is correct for her body weight, the speed is lethal.
Exactly. So the rule is, give the loading dose slowly, infuse it over 30 minutes, or give it in divided oral doses. Give the drug time to commute to the suburbs while you are pouring it in. The book's phrase is perfect. Slow administration is prudent.
That really brings the dose-to-destination concept alive. It's not just a number you write on a pad. It's a dynamic fluid system you are managing in real time.
It is. And there is one final wrinkle in time that we shouldn't skip because it's a common source of error, the warfarin delay. Sometimes, even when the PK is finished, the drug is at steady state, the concentration is perfect, the patient isn't better yet.
This is a pharmacodynamic lag, a PD lag.
Right. Warfarin is a blood thinner. It works by inhibiting an enzyme that recycles vitamin K, which is needed to make clotting factors. Warfarin hits that enzyme fast. Boom. Enzyme is stopped. The factory is shut down. But the patient's blood still clots perfectly fine for days. Why?
Because the drug stops the production of new clotting factors, but it doesn't do anything to the old ones that are already circulating.
Exactly. You have a big pool of active clotting factors already circulating in your blood. They are the workforce. Warfarin shuts down the hiring of new workers, but you have to wait for the old workforce to retire and die off naturally.
And the half-life of those clotting factors is?
It varies, but it's on the order of 14 to 60 hours, so you have to wait days for the biology to catch up to the chemistry. This is why doctors don't just keep upping the dose of warfarin if the blood test isn't perfect on day 2. You have to respect the physiological lag.
This has been a whirlwind tour. We've gone from the pill in the hand, to the molecule in the liver, to the hiding spots in the fat, to the drain pipe of the kidney. Let's try to synthesize this for the listener. If they're walking away with a mental checklist for thinking about any drug, what is it?
I'd summarize the journey like this with 4 key questions. 1, absorption A. This is the toll booth. What are the bioavailability of F? What's the price of entry? And remember to beware the liver's first pass tax. 2, distribution. D. This is the geography. What's the volume? Does the drug stay in the blood or is it hiding in the tissues? 3, clearance. CL. This is the engine. It's the most critical parameter for long-term maintenance. It's the volume cleared per minute. And always, always watch out for aging kidneys. And 4, half-life, T12. This is the clock. It dictates your dosing schedule and it demands your patience. You have to wait 4 to 5 half-lives for steady state.
And above all else.
Above all, you have to treat the patient, not the textbook. The equations give you a starting point, a rational first guess. But every single patient is a unique biological experiment. The target concentration strategy is iterative. You predict the dose, you give the dose, you measure the result, and then you revise the math. Science is always iterative.
Before we sign off, I want to leave the listeners with that one final provocative thought you mentioned in the pre-show. The idea of the ghost in the system.
Ah, yes. The terminal half-life. We tend to use simple math, the one-compartment model, where the body is just a single bucket. It makes the calculations easier. But the body is truly multi-compartmental. There's the blood, the organs, the fat, the bone. Sometimes you stop a drug, you measure the blood levels, they drop quickly, and then they drop to 0. You think it's gone. But remember those deep tissue reservoirs? The fat, the bone, the sponge we talked about with chloroquine.
It starts to slowly leak back out.
Exactly. As the blood level drops to 0, the equilibrium shifts. The drug starts trickling back out of the deep tissues into the blood, just a tiny bit at a time. It creates a long tail of elimination. A terminal half-life that is much, much longer than the initial, more obvious half-life. For some drugs, small subclinical amounts can linger for weeks, months, or in some cases even years after the last dose was taken.
The ghost of the dose. It really makes you question, when is a drug truly gone from the body?
It's a very good question to ask.
For those of you who want to see the specific graphs we talked about, the sawtooth accumulation curve, the nomograms for calculating doses, go to Ketum's chapter on Pharmacokinetics and Goodman and Gilman's chapter on the same. The diagrams are absolutely essential to visualize the math we talked about. This deep dive is your map, but you still need to walk the territory.
Absolutely. Read the chapters. There's no substitute.
Thanks for listening. We'll see you in the next deep dive.
Take care.